So I welcome you all in today's clinical combined round to be presented by Department of Dermatology and Venereology. And we are presenting a case. We have titled this as facial and scalp ulceration, unveiling the hidden pathology. And we have chosen this case because it has taught us few things. The first thing which this case has taught us that even if you find one answer, but you couldn't find the solution, you should keep your mind open. You should be ready to accept the change in diagnosis, additional diagnosis, change in intervention, because the ultimate goal is management of patient. And the second thing which it has taught us, the importance of multidisciplinary collaboration or a teamwork, which is the kind of essence of our institute or a beauty of our institute, because it saves life, and you will see in the case. So to start the case without taking much time, I'll invite Dr. Savi. She'll present the case history. Thank you.
Good afternoon, all. I'll be presenting this case of female infant who presented to us on day 51 of life with multiple ulcerations involving face and scalp. Those ulcerations were mainly present in perioral, periocular, and periauricular region covered with crusting. Because there was crusting, the baby was having difficulty in feeding and difficulty in breathing. And this difficulty in feeding led to substantial weight loss as well, which the parents noticed over a period of 1 month. At birth, the mother noticed that there was some dusky erythema involving face and scalp, which the treating doctors attributed to birth trauma, and nothing was done at that time for that. And the baby started developing multiple ulcers, starting from right angle of mouth, which developed at 4 days of life. And this ulcer was eventually covered by crusting and later by scar. Since no specific treatment was received, the baby continued to develop multiple ulcers and presented to us like this on day 50. The antepartum intrapartum history was within normal limits. She was born at 36 plus 1 weeks of gestation, spontaneous vaginal delivery. Birth weight was appropriate for gestational age. No maternal history of rash, fever, genital or vesicular lesions in the mother. Then baby cried immediately at birth, but required 2 days of NICU stay because of respiratory distress, which she developed soon after birth. There was no history of maculopapular lesions, vesicles or petechiae, purpura, any lesions of over the other parts of body, no history of other ocular complaints, no history of jaundice or abdominal distension, no history of seborrheic dermatitis, no history of seizures or bulging fontanelles or hydrocephalus. On examination, baby was oriented, however lethargic and markedly emaciated. As compared to birth weight, which was about 3 kg, the weight was substantially reduced. It was about 2.2 kgs on presentation. Baby was vitally stable. However, there was some some breathing difficulty. On examination, we noticed that in addition to the defined ulcers with peripheral pustulations, the baby also had on the background of that some dusky diffuse erythema, which was mainly present in B1 and B2 distribution of a trigeminal nerve, which we can see better in this image. It was limited to the V1, V2 distribution, and the ulcerations which were present in the periauricular, periocular, perioral region, they were also involving the nasal septum. So, depending on these clinical features, we kept the differential diagnosis of infantile hemangioma with secondary bacterial infection, varifaces syndrome, then torch infections, HSV infection, and neonatal Langerhans histiocytosis. The initial workup showed leukocytosis and deranged liver function tests. Further disease-specific workup was done. In torch profile, baby had positive CMV, rubella, HSV, IgG was positive. In mother's torch profile, it was positive for CMV, IgG, signifying past infection. PCR was run on the blood of the baby, which showed positive copies, about 2 into 10 to the power. CMV PCR was done on blood, which showed positivity for CMV, and 2 into 10 to the power 5 copies were present. After treatment, the next PCR which was run, it was negative. And then skin scrapings for HSV PCR also came negative. Further secondary infections were evaluated, which showed the pus culture positivity for Enterobacter hormesis sensitive to piptas and meropenem, and as the epidermidis the sensitive to vancomycin linezolid. Blood culture was also positive for S. epidermidis, which was sensitive to vancomycin. CSF culture was negative. Further imaging was done, in which USG abdomen did not show any hemangioma-like lesions in liver. Then skeletal survey was done, which did not show any osteolytic lesions, thus keeping the diagnosis of neonatal LCH lower down. Then 2D echo was normal and ophthalmological evaluation was also normal. And MRI brain was done, which I will ask a senior resident from Department of Radiology to describe later. Dr. Manish.
So we have only MRI brain available for this patient among the in-house imaging. So on the axial coronal sagittal images, we can see in the posterior fossa, this is the normal right cerebellar hemisphere. On the left side, the cerebellar hemisphere appear very small in size compared to right side with distorted gravity differentiation, which is suggestive of hypoplastic and dysplastic left cerebellar hemisphere. On the mid-sagittal plane, we can see that the vermis is not visualized, suggestive of vermin hypoplasia. Next slide. So the key findings were dysplastic left cerebellar hemisphere with vermin hypoplasia. The supratemporal part of brain was normal. So based on the clinical findings, which was the facial hemangioma, we raise a possibility of the face syndrome, which includes the posterior fossa malformation, the facial hemangioma. Apart from that, we can also have the arterial anomalies, any cardiac anomalies or eye anomalies.
Further evaluation of the baby was done in NICU. So I'll invite Dr. Ritesh from Neonatology to describe the course in NICU.
Thank you, Dr. Savi. So the baby presented to us with a progressive, since birth to progressive ulceration of the lesion since 1 week. So the baby, as my colleague had already discussed how we had worked up. So the first skin lesions, paraffin gauze was applied and mucorous ointment was applied. For the care of eyes, which has a little eye drops were given and antibiotic drops were applied. And for pain, as the baby was persistently having tachycardia and baby was agitated, so we started with paracetamol. However, the baby did not respond, so we also had to add oral morphine. For bacterial infection, as already mentioned, baby had grown to culture from pus culture positive. For that, piperacillin tazobactam given for 10 days. Amikacin was stopped after 6 days. Once the cultures had come in, first step epidermidis for blood culture positive, vancomycin was given for 14 days. The baby to begin with was started with acyclovir. However, as the skin scraping had come out to be negative, so we stopped after 6 days. For CMD, we had started on valganciclovir, but however, along the course, we had done a BERA, for which the baby had actually left-sided severe hearing loss. So with such high copies, with symptomatic in the form of hearing loss, so we continued valganciclovir. However, a possibility as this investigations we had discussed, even despite doing all of these, by day 72 the baby's lesions did not improve. So we considered with a history of infant like hemangioma like lesions at birth. So we considered infantile hemangioma. Dermatological opinion was taken, and we had started propranolol. We had also asked the history with the mother as to whether there was any application of any homemade any remedies or any corrosives were applied just to get away with the lesion. So nothing of that sort was done. So likely it was infantile hemangioma with complications in the form of ulceration. Also, as there was dermatomal involvement, so we also considered faces as a possibility. So when we investigated along those lines, and baby was noted to have cerebellar hypoplasia. Baby on day 85 of life had respiratory distress with desaturation, and baby was initiated from room where the respiratory support was high to CPAP support. However, with a left-sided lung filtration, some infiltrates. On day 89 of life, initially we considered possibility of a viral etiology. And the baby had progressively worsening respiratory distress, and after 4 days, baby had to be mechanically ventilated with ECV mode of ventilation. So we consider a bacterial etiology, and piperacillin tazobactam and amikacin was started, which was given for 7 days. This is a first line of antibiotics in unit. The blood cultures were negative during this episode. Baby after 2 days was extubated to NIPPV, or that is non-invasive positive pressure ventilation. The baby post extubation had stridor with posturing. Now the possibilities during this episode considered was gastroesophageal reflux, for which anti-reflux measures were taken. The other possibility, as the baby was on morphine and we were tapering dose of morphine, so another possibility of neonatal opioid withdrawal was kept. And the baby's dose of morphine was again increased to the previous dose. The other possibility of subglottic stenosis was kept, and the baby was intubated along with the baby having an hemangioma involving the beard and the major area of the face. So likely possibility of an area hemangioma was also considered. So for subglottic stenosis, as the baby also had stridor, so we gave intravenous dexamethasone, and we also continued with adrenaline nebulization. Maybe during this episode, CSF examination was done. The CSF was not suggested for meningitis. So, considering the possible subglottic stenosis, we went ahead with the bronchoscopy. So, the bronchoscopy did suggest a subglottic stenosis, that is grade 2. So, for that, an ENT consultation was taken, and on day 98, the baby under general anesthesia underwent balloon dilatation of the subglottic stenosis, and baby was intubated for a day and re-extubated to NIPPV support. Baby on day 94 of life had seizures in the form of tonic movement of the limbs with uprolling of eyeballs. The receptor was loaded and started as maintenance. The CSF that was not severe meningitis, electrolytes were normal. We had a MRI brain that had an underlying cerebral hypoplasia with no cerebral lesions. For opioid withdrawal, the baby has continued on oral morphine. And during this episode, subsequently the baby has started early stimulation and physiotherapy. And along the course of the hospital stay, the baby was starting on clonidine as a measure to gradually decrease morphine. And morphine was gradually decreased and clonidine was continued. A baby on day 128 was shifted to CPAP. The respiratory support was decreased to CPAP and subsequently to room air. For CMV, as the baby had left-sided severe hearing loss, so we continued with the baby on Valgan cyclover with a plan to give for 6 months. And the baby currently is 5 days more are remaining to complete Valgan cyclover to date. For hemangioma, baby has continued on propranolol of 2 mg per kg per day. As we can see, these were the lesions to begin with. And after starting propranolol, the lesions have subsequently shown improvement. And the ulcerations had also shown improvement. So at day 134 before discharge, the baby was vaccinated of 6 weeks of vaccination, though delayed, and baby was discharged. And this is the post-discharge follow-up. Currently, the baby last had followed up at 6 months of corrected age, for which the baby had all his weight, height, and OFC, which are at normal centiles. And this is the image to begin with, and this is the image of the baby at discharge. I would like to call upon.
So this is the image we have taken 2 weeks after discharge when baby came to dermatology OPD again, and we can see in the ulcerations have healed with certain sequelae like telangiectasias are there and scarring is there. So this is the baby at 2 weeks after discharge. It is 5 months of life. For further discussion, I would like to call Dr. Goli here.
Thank you, Professor Ravi. Now coming to the review of literature of the facial ulceration and scalp ulcerations. So these are the various causes of neonatal facial ulcers we studied. Like we can see that the most common cause is infections like viral infections, herpes simplex virus, cytomegalovirus. The vascular causes like ulcerated infantile hemangiomas, congenital hemangiomas, inflammatory conditions, and also miscellaneous conditions like traumatic ulcers, metabolic and nutritional causes were also considered. So here in our child, so what happened was the torch profile was coming to be positive because the child had periorificial ulcers. So torch was considered as a cause, and the torch profile was done and it came to be positive, and also the child and the mother had CMV positivity. So further evaluations were done and the child was found to have congenital CMV. At the same time, the child was treated, but there was very minimal response with antivirus. So we had to keep another diagnosis as well, and the child was clinically diagnosed with congenital hemangiomas with ulceration after a consultation with dermatology. So these are the various differentiating conditions. So, in case of cytomegalovirus infection, the child had periorificial ulcers, and these periorificial ulcers were present focally, and the child also had hearing loss, and PCR IgM was positive. So, child was fitting into this. And also, the child had ulcerated infantile hemangioma like ulcers because the ulcers were deep with hemorrhagic crusting over the vascular plaque, and they were present over the perioral lip, nose, and cheek associated with infection, and a clinical diagnosis was made. So coming into the congenital CMV infection, CMV is caused by herpes virus 5, and the prevalence of congenital CMV is 0.6 to 6% in developing countries. The transmission ranges from 30 to 50% and it increases up to 70% in the third trimester exposure. There is high risk equally in the first and second trimester, while the transmission rate is higher in the third trimester. The cutaneous manifestation of CMV, they are rare usually in immunocompetent individuals, but if it occurs, there can be diverse presentation in the form of plaques, erosions, petechiae, purpura, vesicles, and building, as shown in this picture. Here we can see that the child is having violaceous papules nodules, and this is blueberry muffin rash of CMV. The child can even present with maculopapular exanthem, or with petechiae purpurae, or with perianal perioral ulcerations, or even with rare lesions like pustules, vesicobular lesions, and nodules. So this is a child with perianal ulcer associated with CMV. The ulceration in CMV is very rare, but the common site of ulceration is perianal more than generalized, more than perioral, more than lower lips. There is currently no established guidelines for the treatment of cutaneous ulcers due to CMV. The treatment strategies are extrapolated from the existing successful treatment of the solid organ CMV infection with IV ganciclovir and oral valganciclovir. The first sign of response is expected by 1 to 2 weeks and the complete recovery in 1 to 2 months. Then regarding the course of ulceration in infantile hemangioma or phases, the ulceration occurs in approximately 16 to 23% of infantile hemangiomas and usually by the median age of 4 months during the proliferative phase. And it can be associated with complications like bleeding, secondary infection, etc. The pathogenesis of ulceration in infantile hemangioma is unclear, maybe due to ischemia and necrosis from trauma friction or due to rapid tumor growth which is exceeding the oxygenated blood supply. And in our case, there was a rapid ulceration of the infantile hemangioma. The baby was 51 days old, and the rapid ulceration we have attributed maybe to type 3 hypersensitivity reaction, the reaction to the circulating viral antibody immune complex resulting in microthrombosis and vascular occlusion. Phases comes under high-risk infantile hemangiomas, and it is associated with posterior fossa malformation as we have seen in our child who is having cerebellar hypoplasia, and also associated with arterial anomalies, cardiac defects, eye anomalies, and sternal defects. And the criteria of phases is the presence of segmental infantile hemangioma larger than 5 cm of the face, scalp, and cervical region, associated with one major criteria or two minor criteria. Here the child had the posterior fossa brain anomaly which falls into one major criteria, thus fitting into the diagnosis. And in case of infants with large facial hemangiomas, almost 1/3 of the patient had phases. And among them, like most of the patient had lesions over the S1 segment, trigeminal segment. And also the most common complication associated with such lesions were cerebrovascular anomalies. Here we can see that as the size of the infantile hemangioma increases, the chance of PACE syndrome also increases. Treatment of ulcerated infantile hemangiomas. Various studies were conducted, and the first line agent is the propranolol, and it was seen that in various studies that the mean healing time of these ulcerated infantile hemangiomas varied from almost 3 weeks to 6 weeks, and in our child it almost completely healed in 4 to 5 weeks. As in ulcerated hemangiomas and also in infantile hemangiomas, we know that propranolol is the first line of treatment. Mechanism of action being vasoconstriction, inhibition of VEGF, and also induction of the apoptosis of the capillary endothelial cell, resulting in healing of ulcers and rapid improvement in the complication. And the lesions heals with scarring and erythema and telangiectasia in case of ulceration. So this was a study, this was a case from our department where there was a dramatic response to propranolol in this child. So this is a case of phases, and we can see that there were no ulcerations, so the lesions healed without scarring. And also, a multi-center cohort study had been conducted which showed that in patients with phases, oral propranolol can be given without any reported serious adverse effect. Still, we should be very careful while giving propranolol to children with phases. Prior echo should be done to rule out aortic arc coaptation, and also the lowest possible dose should be used. So in this case, initially the child was diagnosed as CMV, but it's not a misdiagnosis, but rather it's a dual pathology that we are considering. The hemangioma ulceration, which resembled the perioral CMV ulcers, workup led to the diagnosis of congenital CMV in this child, but the child had features of both phases and ulcerated CMV. So the CMV infection was positive in the child. The child also had systemic features of CMV like transaminated sensory neural hearing loss, and also the child had ulcers over overlying hemangiomas only, and also had this neurological criteria of phases, cerebellar hypoplasia present in the child, and also with minimal response to antivirals and rapid response to propranolol, phases was considered. So the teaching point is that infant with large cervicofacial segmental hemangioma, any hemorrhagic crusted ulcer over the plaque is typical of phase-related hemangioma ulceration and not a primarily ulcer disease. And so prompt initiation of oral propranolol in ulcerated infantile hemangioma helped accelerating the healing. And in case of early rapid onset of such ulcerations in infantile hemangioma, we should rule out underlying viral infections like CMV, herpes, etc. In case of dual pathology, in this case, here we have both phases and congenital CMV. So treatment with both oral propranolol and valganciclovir was required in the child. Thank you. Now the case is open for discussion.
Thank you, Savi, Gauri, and Dr. Ritesh and Dr. Manish. Seturaman sir, do you want to come in because the case was seen and managed by you?
Only thing is, we see multiple ulcers like this, we think of often episode. This time, had large deep-seated ulcers, and so often you see this in the deep-seated ulcers.
CMV, the commonest clinical presentation cutaneous is blueberry muffin or papillonodular. We could only find few case reports, sir, where the perianal ulcer, as Gauri has shown, in 2 or 3 case reports, that was the presenting manifestation.
We have a team here with the experience of seeing CMV infection or touch the hematology image.
With this such a ulceration presentation, we didn't have much experience. However, the first case where we basically primarily treated the baby as a facial syndrome and associated CMV infection. We didn't have much experience. Ultimately, we have not seen person involved.
Thank you. Thank you. Any other question? They were confined to the human. I'll just show you the picture again.
So if we are thinking of CMP, then there are very wide variety confined.
So, as Gauri has reviewed the literature and kind of postulated a theory that maybe the hemangioma got ulcerated very rapidly, that is at age of 4 days, and was confined because of associated type 3 hypersensitivity, and we did not have a lesional CMV positive. So it's just an hypothesis that may be a reason of co-occurrence of two pathology at a same site. Right, Gauri? Anything to add?
Plus, that not disseminated also.
I understand. Correct.
Not
Only on the hemangioma. So it's possible that the CMV led to ulceration because there was an underlying pathology. It prompted it to ulcerate. Sir, because of the positive antibodies in the mother, in the child, PCR was positive, so we could not ignore it as an incident. Yes, also rapid ulceration. Usually, when we reviewed the literature, 4 months is the age of ulceration, mean age for the infantile hemangioma at the peak of proliferative phase. Here we could see at age of 4 days. So something has triggered that rapid ulceration. So we thought probably CMV is the agent. Which one? Right.
Because we expect proliferating.
Since it was very young child, flat.
It was like a period of time. The child, I think,
Thickening. It started thickening.
Right.
Any other question or we should conclude? I would specially thank Seturaman sir, Dr. Shreya, our senior resident, Savi, our junior resident, Gauri, and Dr. Ritesh and team of neonatology, Dr. Manish from team of radio diagnosis. Thank you. Thank you for your attention.